Yeah, everything you wanted to know about moles in 20 minutes, okay. I have no disclosures. At the end of this talk, I hope everybody will be able to explain the risk factors for hydatidiform moles, describe the genetics of hydatidiform moles, understand the pathology of complete and partial moles, be able to diagnose a hydatidiform mole based on a presentation, manage a mole, including twin pregnancy and normal fetus pregnancy, delineate the risk factors for the development of postmolar gestational trophoblastic neoplasia and possible role for prophylactic chemotherapy, develop a follow-up plan after evacuation of a hydatidiform mole, and to define postmolar gestational trophoblastic neoplasia. There's a wide regional variation in the incidence of molar pregnancies, initially reported to be as high as 11.5 per thousand pregnancies in Indonesia, and compared to less than 1 per thousand in the United States. Other people have estimated that there's a 2 to 3 times greater prevalence of in Southeast Asia and Japan of approximately 2 molar pregnancies per thousand pregnancies than in North America, Europe, Australia, and New Zealand, which is around 1 per thousand pregnancy. But this is usually due, at least in part, to lack of standardization of data collection and reporting. Usually when you have hospital-based reporting, you have overestimation of the incidence because you have higher incidence of abnormal pregnancies versus population-based studies. There also have been reports of higher rates in Native Americans, Eskimos, Hispanics, African Americans, and Asians. I think a lot of these are due to socioeconomic reasons and diet rather than genetic or cultural factors, which have contributed to this variation in incidence rates. And this is pointed out by declining rates in the incidence of molar pregnancies in Korea, attributed to the increasing in the Western diet and improved standard of living. It's also, there are 2 case-controlled studies that looked at decreased consumption of dietary keratin, a vitamin A precursor, and animal fat related to an increased rate of molar pregnancies. So overall, at least in most in the United Kingdom and in the U.S. and most of Europe, the overall incidence of a complete mole is approximately 1 per thousand pregnancies, and it's been estimated maybe partial moles as high as 3 per thousand pregnancies. The 2 most important risk factors for the development of complete hydatidiform moles is maternal age and prior complete mole. We know that women who are less than 20 years old have approximately a 2 times increased rate of complete molar pregnancy per pregnancy event. And women over the age of 40 have approximately 7.5 times the rate of molar pregnancy per pregnancy event. Also, patients who have had a complete hydatidiform mole are at increased risk for a second molar pregnancy. It goes from approximately 1 per thousand up to 1 per 100. There are some other factors that may affect the epidemiology of a hydatidiform mole, complete mole, but these are less important. As far as partial mole, it appears that a history of spontaneous abortion and a history of irregular menses may be risk factors for partial mole. I borrowed this slide from Michael Seckel and his group, and that talk about the genetics of molar pregnancy. Most complete moles occur when a sperm fertilizes an empty egg, or an egg in which the genetic material is either absent or doesn't participate in the reproductive process. Once the fertilization occurs, then the haploid chromosome complement of the sperm then replicates itself. So you end up with a 46XX mole where all the genetic material, nuclear genetic material, comes from the father of the mole. We know that there's a maternal contribution because you can find maternal mitochondrial DNA. If you don't have a maternal component to a pregnancy, there's no fetus that's formed. The placenta grows then uncontrolled and forms this big cystic mass of tissue. About 90% of complete moles are formed that way. About 10% of complete moles are result from dispermic fertilization of an empty egg. There's also what's called a diploid biparental complete hydatidiform mole, which is a normal fertilization of a sperm and an egg, but there's a somatic genetic abnormality, the most common being NLRP7 somatic abnormality on the chromosome 19. And these people will have repetitive hydatidiform moles, and there's nothing you can do about this other than use donor egg. Partial moles are formed when there's dispermic fertilization of a normal egg, and so you end up with triploid, which is the genetic composition of a partial mole. Complete moles are, you can tell what they are grossly because there's gross hydropic degeneration and swelling of the villi, and there's usually absence of an intact fetus or embryo. Microscopically, the trophoblast is proliferating. There's hydropic degeneration of the villostroma and scantiness of blood vessels within the mole. This is you can see that this is a hydatidiform mole that's been removed by hysterectomy and preserving the nice placental gamush along with these vesicles there and no fetus or embryo. Hydropic villi, absence of blood vessels within the villi, and trophoblastic proliferation around the entire circumference of the villus characterizes the complete mole. You can identify at least two types of trophoblast, the cytotrophoblast, which are the mononuclear vacuolated cells that then are involved in growth and replication of the trophoblast, and the syncytium or syncytiotrophoblasts, which are derived from the cytotrophoblast by a process of membrane dissolution and coalescence, and they're involved in membrane transport and hormone production. Partial moles, you can usually identify a fetus or embryonic tissue of some type. The chorionic villi are varying size and shape. There's focal edema and scalloping of the villi, prominent stromal trophoblastic inclusions within the villi, functioning villus circulation, still focal trophoblastic hyperplasia with only mild atypia. You can do IHC staining, which is positive for P57, which is a paternally imprinted, maternally expressed gene, and these are triploid. P57 is also positive in spontaneous abortions, but not in complete moles. It's an example of a partial mole. You can see on one side of the slide the typical hydropic villi and this placenta, and on the other an abnormal fetus. These fetuses are always abnormal, they're triploid. And here you have the scalloping of the villi. You still have a venous circulation within the villi and some trophoblastic inclusions, and not as much trophoblastic hyperplasia. Most complete moles present with vaginal bleeding, but the presentation has changed significantly since the 1960s and 70s to the present. So fewer patients have the classic uterine enlargement greater than dates. There's a much lower incidence of medical complications of the molar pregnancy, such as toxemia or preeclampsia, hyperemesis, hyperthyroidism, trophoblastic embolization. You still will have some bilateral thecalutean cysts, which you can, in about 15% of patients, and absence of fetal heart tones. Partial moles present very differently. They don't have the classic features of complete mole. About 75% present with vaginal bleeding, but excessive uterine enlargement, hyperemesis, hyperthyroidism, thecalutean cysts are develop infrequently. Only about 10% have HCG levels greater than 100,000 milli-international units per ml. About 90% have symptoms and ultrasound findings which are consistent with incomplete or missed abortion, and the diagnosis is usually made only after histologic examination of curettage specimens. The reason that we now have fewer complications from hydatidiform moles is because of ultrasound, and we're able to diagnose these earlier. They have a characteristic vesicular pattern consisting of these multiple echoes or holes within the placental mass and usually no fetus. We also are able to measure human chorionic gonadotropin easily now in most places, but approximately 50% of complete moles have an HCG level greater than 100,000 milli-international units per ml, but there is no HCG level in the end of the first trimester that is incompatible with a normal gestation. A single HCG level is seldom of value, therefore, in differentiating a complete mole from another type of pregnancy. Earlier diagnosis of complete moles has resulted in these fewer complications, but interestingly, there's been no difference in the incidence of post-molar gestational trophoblastic neoplasia. This is a classic picture of an ultrasound of a hydatidiform mole with multiple holes within the placental mass and no fetus or embryo. Once you've made the diagnosis of a hydatidiform mole based on the clinical presentation, your examination, and an ultrasound, you then need to proceed to evacuate the mole from the patient. We should do some preoperative blood work, including platelets and CBC, some chemistry, some liver function tests, at least a type and screen. In patients who have a large or a mole, we also obtain a coagulation profile, a thyroid panel, and a type and cross match. We do an HCG as a baseline, get a chest X-ray, and pelvic ultrasound. We then proceed to evacuate the mole from the patient by one of two methods, either by suction, evacuation, and curettage, preferably under ultrasound guidance, or by hysterectomy. In the operating room, we now dilate the cervix and use a fairly large curette, usually a 12 to 14 size curette. We place the curette into the lower uterine segment and turn the curette around and suck the molar tissue down out of the fundus of the uterus. When you have a large mole, the anesthesiologists get very concerned. They've put two large bore IVs in. They have some blood available. And they notice that as soon as you turn on the suction, there's a large amount of bloody material that comes out of the uterus. And next thing you know, they think that that's connected to the patient's aorta. And they've given the patient a lot of fluid. They brought the blood in. Next thing you know, the patient's in congestive heart failure, and they claim that, oh, there's been trophoblastic embolization. No, it's not. It's because you gave too much fluid. And so now we cover up that suction canister. We assign one of our students or residents to the anesthesiologist to watch what they're doing so they don't screw this up. But most of the time, this goes very well. A hysterectomy is a good form of evacuation of the mole in a patient who has an increased risk for post-molar gestational trophoblastic neoplasia or desires sterilization procedure. There is no place for medical induction of labor or hysterotomy in the management of molar pregnancy. If the patient is Rh negative, you should provide that patient with immune globulin. The patients who are at the highest risk for post-molar gestational trophoblastic neoplasia are those with uterine size greater than dates or a uterus greater than 20-week size, those with phacolutean cysts, age greater than 40. Remember I told you that age greater than 40 and less than 20 are at increased risk for molar pregnancy, but only the older patients are at increased risk for the development of post-molar gestational trophoblastic neoplasia. Medical complications such as toxemia, hyperthyroidism, trophoblastic embolization also place the patient at greater risk for post-molar gestational trophoblastic neoplasia, and patients who have had a prior hydatidiform mole. What's the place for prophylactic chemotherapy at the time of or immediately after evacuation of molar pregnancy? We know from several studies that it's associated with a reduction in the incidence of post-molar gestational trophoblastic neoplasia from about 15 to 20% down to 3 to 8%, but it should be limited to special situations, and that is where the risk of post-molar gestational trophoblastic neoplasia is much greater than normal and where there's not adequate follow-up available, because essentially all patients who are followed with serial HCG testing after molar evacuation and found to have persistent GTN can be cured with appropriate chemotherapy. Twin pregnancy comprising complete mole and normal fetus occurs about once in every 22,000 to 100,000 pregnancies, and it must be distinguished from a partial mole or triploid pregnancy with fetus. The diagnosis is usually established by ultrasound. Cytogenetics may be useful to differentiate between a chromosomally normal pregnancy and with a potentially viable fetus and a triploid non-viable fetus. It's an ultrasound of a twin mole normal fetus pregnancy, and you can see on your left the normal fetus. On your right, on the top, there's a anterior normal placenta and a posterior molar pregnancy. And then on the bottom, you can see both the fetus and sort of the molar placenta the same. So this is fairly easy to diagnose. These patients are at increased risk for hemorrhage, medical complications, and development of persistent gestational trophoblastic neoplasia. If the patient desires pregnancy termination or the patient has a lot of bleeding, suction evacuation and curettage in the operating room under ultrasound guidance is recommended. But up to 40% of these pregnancies may result in normal viable births if allowed to continue. And there are several case series from lots of places, but the largest is from the Charing Cross Sheffield, UK experience, where they had 90 patients with complete mole and co-twin. 57% of those patients elected to continue their pregnancy. Of the patients that elected to continue the pregnancy, 57% of those, or 29, delivered a live baby, so that 32% of all the patients ended up with a live baby with a median gestational age of 34 weeks. 27%, or a higher number, developed gestational trophoblastic neoplasia, but there were no maternal deaths, importantly, in this series. Once you've evacuated the mole from the patient, either by suction evacuation or hysterectomy, or if a patient has a twin pregnancy by delivery, you need to follow serial serum quantitative HCG levels every 1 to 2 weeks until negative for 3 consecutive determinations, and then every 3 months for at least 6 months. Patients who have partial moles, you could probably delete that follow-up as long as their HCG has returned to normal spontaneously on one occasion. Postoperative physical examination should be performed in 1 month to assure that the patient is doing well, that the thecolytic cysts are resolving, the uterus is contracted down, the patient's not bleeding, or have any other complications. And contraception during follow-up period for 6 months after spontaneous return of the HCG to normal is recommended. The indications for treatment for postmolar gestational trophoblastic disease are plateauing HCG levels for 4 values over 3 weeks, rising HCG levels greater than 10% for 3 values over 2 weeks, persistently elevated HCG levels 6 months after evacuation, or a histopathologic diagnosis of choriocarcinoma or detection of metastases. This is a group of patients we followed at Northwestern when HCG testing wasn't available most places, so we had 738 patients we followed after evacuation of hydatidiform moles, and of those, 81% went to normal spontaneously. None of those patients ever required any treatment. We elected to treat 19% of the patients based on a plateau or rise in their HCG, and all of those patients were cured. This is pretty simple, seems like. I want to also point out that the NCCN, National Comprehensive Cancer Network, recently came up with some NCCN guidelines for management of moles and for gestational trophoblastic neoplasia, and there's no reason to concentrate on this very much. I just wanted to point that out to you, that these are available. Thank you very much for your attention.
John, could we just keep you on the stand for a moment, just in case there are any questions from the audience? So does anyone want to ask anything about management of moles?
John, I've too fast.
I've got one for you. Why do you think that the risk of developing GTN after a twin molar pregnancy is higher compared to after a singleton molar pregnancy?
I have no idea. I think that, and it's been replicated almost in every case series too. And so I think it may have to do with the patients that had their pregnancy allowed to continue, maybe, and therefore the molar placenta has grown into the wall of the uterus, and it's more likely that there's invasive mole there, not choriocarcinoma.
Yeah, I mean, I like you, I don't have an explanation. Are there any other questions? Oh, there's one over there, yep.
Yeah, I want to know if the indication for treatment for post-molar gestational trophoblastic neoplasia. If persistently after 6 months, you have the values are high, the HCG values are high, but then it's coming down, do you still go ahead and treat or you just follow up?
Okay, we've been debating this in our society for a long time, and it's still part of the FIGO recommendations for treatment. Yes,
Take it
and that has been our policy at Northwestern as well. That, you know, the HCG should go down to normal pretty quickly after pregnancy, and so if it persists that long, something's going on, and so we do recommend treatment, although that's not a universal feeling. In Europe, I believe they're continuing to follow those patients.
Yeah, just to update that our recent sort of guideline from FIGO, we propose that we can consider taking away the 6 months, but we allow individualization. So if you think that you need to treat, then you can, but we actually have just this year taken it out of our guidelines. Yeah. So, shall we? Okay. So thank you very much, Sean.